Hey everyone, welcome back to Karan Academy. My name is Karan, and today we're going to be talking about infections of bones and joints, and namely osteomyelitis and septic arthritis. Now, both of them do tend to be pretty commonly asked questions and examined, so let's jump into it. Let's start off with septic arthritis. So what is septic arthritis? As the name suggests, it's an infection of the joint itself. Now, this can happen in both native and prosthetic joints. They do tend to be quite common in prosthetic joints because of, surgical complications. But I guess the more prudent question is, how can a bug get into the joint? This will also determine, I guess, what bugs we're dealing with, and then what specific questions you're going to ask during the history that are going to guide your choice of therapy for these patients. So firstly, you have hematogenous spread. So I used to think that, well, septic arthritis, infection of joint, I know that if stuff goes into joints or if joints get exposed, that's what's most commonly going to be causing them. But turns out hematogenous spread is the most common cause of septic arthritis, which means that there are bugs in the blood from somewhere else that are then entering the joint. So things like wound infections, abscesses, and so forth. And it's not direct infections that are most common. You still can get obviously direct infections from any exposure to the joint. So this includes recent injections, stuff like corticosteroid injections, if they've had recent surgery, any penetrating trauma, obviously. And then with any joint, of course, it's a junction of two bones. So if you have an infection in either of the two or more bones, that can also lead to spread from those bones, and that's going to be osteomyelitis, then spreading to septic arthritis. Causative bugs, common things are common. So Staph aureus is going to be the most common cause of septic arthritis. You can also get streptococcus as a cause of septic arthritis, but more commonly, or not more commonly, more importantly, I guess, if you have multiple joints being infected, you always have to think of Neisseria gonorrhea as a cause of septic arthritis, because it can present in those with disseminated disease. How does this present? So it presents quite acutely to subacutely. So we're usually talking hours to days, in some cases weeks, but that will be the subacute category. It presents with a triad of fever, joint pain, and reduced range of motion. On examination, you would notice the joint being quite swollen, tender, red, warm. So all things that make you think infection, right? A few extra bits to note. When I say the ROM is reduced, I mean that it's almost non-existent. They will be in such excruciating pain that they will find it incredibly hard to move the joint at all. So if you see someone and they can still move their foot, their joint through the entire range of motion, but it's just painful, it is quite unlikely to be septic arthritis. Secondly, the other condition that presents quite similarly, and often can be a case of one leading to another, is gout, where you have a swollen, red, warm, and painful joint. This is going to be your second most likely differential diagnosis. And regardless of which one or minute risk factors, you will be doing a joint aspirate. This is really key, and don't forget this, please. In terms of investigations, as I said, please tap the joint. So we're talking about an arthrocentesis or a joint aspirate. It's both diagnostic and therapeutic. As you can imagine, if this was an infection or if this was septic arthritis, you are going to have fluid buildup, pus that's going to be full of neutrophils and all types of exudates. That's going to be applying further pressure onto the joint capsule and will be quite painful. So it's also therapeutic in terms of reducing that pressure within the joint. Or if there's also a hemarthrosis, which is a collection of blood in the joint, you're going to help to reduce that as well. When to not do a joint aspirate, if there is overlying cellulitis. So if this appears to be a case where a patient had an overlying cellulitis, which then you think led to septic arthritis, you wouldn't be jumping straight ahead into doing a joint aspirate. As to whether or not you'd end up doing one, I think that's a very subjective question that you do not need to trouble yourself with at this point in time. So what would you see with a joint aspirate that is suggestive of septic arthritis? So you would see an increased white cell count, predominantly neutrophils. Again, remember, the most common cause are going to be bacteria. So you're going to have a neutrophilia. You're going to have reduced glucose, because the glucose is going to be consumed by bacteria. So you can have low levels of glucose, and you're also going to do a gram stain. So the thing you need to know with septic arthritis is that it's really bad and you can often lose joints and bones and limbs. So you want to start them on antibiotic therapy as soon as possible. A gram stain, is this gram positive or gram negative, is going to be really key in guiding empirical antibiotic therapy. So let's say if you do a gram stain and you have a gram positive, of the three common bugs we mentioned, the two most common were staph and strep, both of which we know are gram positive. Then again, depending on how they clump up together, you can often, I guess, pretty confidently say whether this is staph or strep. So if it's that typical grape-like bunching structure, that's going to be suggestive of staph. What it does not tell us is about sensitivities. So even though it may tell us that this is staph, whether or not that staph is sensitive to flucloxacillin, which is going to be your main antibiotic of choice for staph, is another question, which is why we also do an MCS, which is microcultures and sensitivities on anything that we do grow. And again, if this were a gram negative, the most common bug is going to be Neisseria gonorrhea with that. You also need to know that a negative gram stain, so not a gram stain that is, so if you see nothing show up at all, it doesn't exclude septic arthritis. And as I said, you would do an MCS for more specific and targeted antibiotic therapy. With osteomyelitis, two points of distinction. So osteitis is inflammation of the bone, which can be because of a lot of reasons. Osteomyelitis is infection of the bone. Again, osteomyelitis will present with osteitis because osteitis is just a very non-specific term. Obviously, infection is going to come in hand with inflammation. The reason you can get infections in bone is quite similar to that of joints. So again, can be hematogenous, which is more common in kids, versus exogenous, which is more common in adults. With hematogenous, so if you think about it, kids, because they are growing and they do tend to have quite a florid blood supply, growth plate, and areas of rapid growth within the bone, you do tend to see hematogenous spread more commonly, versus exogenous, because adults tend to do more stupid things and end up with open fractures. That would be one of the leading causes. And secondly, exogenous spread, meaning direct spread from the outside. So things like wounds, abscesses, and ulcers are the main reasons why you would see osteomyelitis in an adult. We'll get to that in a bit. Unlike septic arthritis, which is pretty acute, so usually days to weeks, hours to days, sometimes weeks, osteomyelitis can be, again, hours, but more commonly it can be subacute and chronic. So subacute being days to weeks, chronic being over 6 weeks. So in terms of signs and symptoms, you'd see a lot of similar signs in terms of general features. So again, there would be pain, there would be tenderness, swelling, warmth, but it tends to be a bit less severe in terms of focal pathology. They do also tend to be a bit more, or have more features that are kind of malingering stuff in the back that isn't really suggestive of OA or OM. They feel unwell, they might have had fevers, they haven't been feeling like their usual self, weight bearing is a bit more difficult. So they're a bit milder symptoms, but they do tend to be pretty long-standing, versus septic arthritis, which is pretty boom, hours to days, you get really sick. Again, with chronic osteomyelitis, you can then end up with swelling and tenderness, yes, but more importantly, things like actual deformities. You can have poor healing of the surrounding tissue, and fevers and chills are less likely if it's that chronic progression. You can also end up with sinus formation, which are these deep cavitating lesions that are just formed within that area. Again, most common bugs are common. So Staph aureus is our most common bug. Some special cases that you need to know. So if a patient has a prosthetic joint, whether it's a hip, knee, whatever, you need to consider Staph epidermidis. Diabetic patients and infants, streptococcus, and diabetics are a big group for getting osteomyelitis. And then the IV drug users, you need to suspect Pseudomonas aeruginosa as being another cause. In terms of investigations, you want to start off with some blood tests. And I always like to go through that as, bedside investigations, blood tests, imaging. So with blood tests, you're going to have leukocytosis or an FPE. Your CRP and ESR are going to be elevated. Again, since ESR is more a marker of chronic inflammation, it is less likely to be up and more commonly seen with rheumatological stuff, but it could be. If you suspect sepsis, if you suspect the patient has had osteomyelitis, which is then spread to the blood or vice versa, you should be undertaking a full septic workup. In terms of imaging, X-ray is often a good initial low-cost investigation. It's not the best. It can miss early OMs because X-ray changes of osteomyelitis are only evident after roughly 10 days to 2 weeks. MRI with and without gadolinium contrast is the gold standard. So in terms of what you would see on an X-ray, as you can see here, so this is osteomyelitis. You can see inflammatory changes of the surrounding soft tissue. And in the X-ray, you can actually see these focal areas of cavitating lesions that are which have increased lucency through them. Again, I am really bad with radiology, but you can just see that it doesn't look quite right. It looks like a bite's been taken out of that. Also to note, MRI with gadolinium, MRI with and without gadolinium contrast. So why do we use gadolinium in the first place? So gadolinium is really good in terms of giving us a good look at the level of metabolic activity within a certain region. So you may have heard of gadolinium contrast with MRIs being used for multiple sclerosis. Again, with osteomyelitis, because there is an increased metabolic activity in those areas of focal inflammation and destruction, you would see gadolinium enhancing lesions. And it's also better for osteomyelitis of the vertebral column. So MRIs are often, you might often jump to an MRI straight ahead if you suspect osteomyelitis of the back. Probe to bone test. Now, this is a really nasty one. I hope you're not eating food at the moment. So it is used typically if you suspect osteomyelitis due to an overlaying ulcer. So this is very commonly seen in diabetics. What you do is you insert a blunt sterile probe into the ulcer. You go as down as you can. And if you hit bone, it is very likely that you're dealing with osteomyelitis because you have that open channel going all the way down to the bone. And that's what you look like. So you literally just stick a probe in there and yeah, see how far you can go. If you hit bone, that's a positive probe to bone test. And then you can also do a bone biopsy in some cases. There are a few important points I want you to know about osteomyelitis specifically. So firstly, systemic markers of inflammation tend to not be as florid as they are with septic arthritis. Patients with OM can often present with low-grade fevers or no fevers at all. So please don't be quick to exclude osteomyelitis in an afebrile patient. Diabetes is a triple-edged sword when it comes to osteomyelitis, if there exists such a thing. Firstly, patients with diabetes get ulcers, and there are common sites for exogenous osteomyelitis. Secondly, you already are going to have impaired wound healing and a poor immune response. So if you do get an infection in there, it is very likely, or it's more likely that your body is not going to be able to fight it by itself. And thirdly, you can have peripheral neuropathy of diabetes. Combine that with osteomyelitis, they will often not feel any pain over an ulcer or over an infected bone, which is why it often goes unnoticed till it's pretty nasty. Fourth point, so unlike most infections, as I said, with septic arthritis, you want to start them on antibiotics as soon as possible, and you don't want the joint aspirate you don't want other things to be delaying your antibiotic commencement. With osteomyelitis, it's a bit different. We know that OM is not going to kill the patients, but what we don't want to do is you don't want to start them on the wrong drug. Why? Because, well, and except if they're septic, but why are we a bit more pedantic when it comes to sensitivities? Firstly, bugs that we see in osteomyelitis tend to often be more resistant to, so they have higher levels of resistance to antibiotics. Secondly, Because they're in the bone, the penetration of antibiotics tends to be quite poor, which means we often have to keep them on really, really long courses. I'm talking 4 to 6 weeks usually. And if we were to start them on an antibiotic for that long, but it tends to be the wrong one, so we haven't sent off sensitivities, we've just started them on empiricals, having someone on the wrong antibiotics for 6 weeks is going to do real damage to their bone, versus waiting for 1 or 2 days is usually a fair trade-off that most ID physicians would be willing to make. In terms of antibiotics, again, go back to our basic principles. So Fluclox, IV, or cefazolin, and you can also start them on vancomycin if MRSA is suspected. When would you suspect MRSA with osteomyelitis? If someone's recently been in hospital, if they've had any hospital-related surgeries, operations, if they've had a hip fixation, that may lead you to think that they may have MRSA, you want to start them on vancomycin. Again, you would still be sending off cultures and waiting for sensitivities to come back. But in some cases, you could just start them on Fluclox IV. That's a very nuanced decision, again, that you will not be making until much later in your career. And as I said, the duration of therapy tends to be quite long, so 4 to 6 weeks, and the rates of response tend to be pretty hit or miss. And that's all we had for today. Thank you all for tuning in. I hope you found that useful. As always, make sure you're looking after yourself this time of year and make sure you're checking in on your friends and loved ones.